Good day and salam sejahtera. I am Dr. Victor Lim, Emergency Physician of Hospitals Barang. So today I'm going to talk to you guys about disaster field triaging. The topic of my lecture will cover on principles of disaster triage, the difference between hospital triage and disaster triage, and I'll be talking about different types of disaster triage, namely start triage, jump start, safe, and sort triage. Okay, I believe some of you has experience in doing hospital triage. What is the difference between hospital triage and disaster triage? Okay, you see, hospital triage is a controlled environment whereby you sit behind a counter and the patient come to you one after another, and you triage the patient according to their severity. So those patients with most severe, you triage to red. Those patients with minor complaint or minor injury, you will triage to yellow. And while those in between, you would triage to yellow zone. Okay, imagine now you are in a disaster scene. Okay, as you can see in the picture, this is a disaster scene of a train derailment. So it involves large number of casualty. So if you are the medical team who responded the scene, so once you reach there, you might easily get lost. You don't know where you should go to, which victim that you should save first, and there are just so many personnel over there. So one might easily get lost if they haven't received any training prior to attending disaster. Next on, we have a shooting scene. So imagine you are the medical personnel and you are the first one to arrive on scene. And all you can see are people running for their life, and people screaming, people crying everywhere. So if you are the first one on scene, how do you approach the scene, right? Should you go to approach the victims, start saving their lives, start giving medical treatment, or you wait for the police to come and control the environment before you start approaching the victims? I'm sure most of you know that the answer is the latter. You wait for the police to arrive and control the scene. And next question, how do you perform an effective triaging and provide treatment to this group of patients? So this one is the picture showing the actual disaster drill that we usually see. Okay, so you have the red zone, the red carpet, the red zone, the yellow carpet, which is the yellow zone, and the green zone is not in the scene because green zone victims usually will be triaged a bit further away from the medical camp, right? So you can see that this probably is a chemical disaster drill, as those victims they have undergone decontamination. All right, they have undergone decontamination before they are relocated to uh, their respective red zone or yellow zone. Right. Then few of the firefighters, they are wearing PPE or personal protective equipments. Right. And outside of the medical zone, you can see that the police are actually cordon the area from the publics. Next, I'd like to talk about the principle of medical response in disaster. Our goal in handling disasters is to maximize the number of victims who will survive the incident. All right. So when we do triaging, basically we can categorize these victims into three categories. Number one, those patients that will live no matter what medical treatment that they receive, right? So these patients, probably we will categorize them into green zone, right? And number two, those patients that will die regardless of the care they receive, Okay, this group of patients probably we should categorize them as expectant, not death, but going into death soon. So this group of patients will receive treatment later. Third group of patients are those patients that will die unless they receive medical care immediately. And this group of patients typically has a good chance of survival. So we want to focus our treatment and resources in this group of patients. Because in disasters, we had a finite or limited number of resources. So we want to use our valuable resources on those patients that will survive if they receive appropriate care. Okay, next, what is the difference between hospital triage and field triage? I believe the difference I have already mentioned earlier in my previous slides. And of course, field triage is performed outside of the hospitals. And basically, field triage is determined by two factors. A, the number of casualties. B, the severity of injuries to the casualties. So if A and B do not exceed the capability of facilities or resources, then those patients with life-threatening conditions are treated first. But if A and B exceed the capabilities of the facility and resources, then those patients with greater chance of survival are managed first. Okay, basically there are four types of disasters triage I'm going to share with you guys. Number one is the start triage. Start triage, also known as simple triage and rapid treatment. Jump triage is mainly used for pediatrics. While short triage, which is getting more popular in the United States, is a new kind of triage, which the full name is short, access, life-saving intervention, and transportation. While safe triage, also known as secondary assessment in victims endpoint, typically we practice inside the medical camp after we have done our start or short triaging. Start triage, also known as simple triage and rapid treatment. This triage is developed jointly by the Newport Beach Fire and Marine Department and the Hodge Hospital in the United States. This triage is most commonly applied by the medical responders in Malaysia. It utilizes standard 4 triage categories and is used for primary triage. The mnemonics to be used in start triage is RPM. R stands for respiration. In respiration, we take 30 as our guideline. Those patient has breathing rate more than 30 per minute is triage rate. Next, P stands for perfusion. For perfusion, the triage officer can either check the patient's radial pulse or he can check the patient's capillary refilling time. So at any moment, if the CRT is more than 2 seconds, the patient is triage rate. M stands for mental status. If at any point the patients can follow the command of the triage officer, then he is triage yellow. If the patient unable to follow a simple command, he is triage red. In start triage, the triage officer only perform two interventions. Number one, opening of airway. Number two, control of massive bleeding. So as you can see, this is a flowchart for the start triage. So a triage officer performing the start triage will usually need a hailer or loudspeaker to gain the attention of the victim. He will shout to the victims and instruct those victims that can move or walk to walk to a place beside the medical camp. So those victims that are able to walk are not automatically triage green. Next, those patients that are unable to ambulate will be assessed one by one. So the triage officer will move to the nearest victim and immediately do the start triaging. It start off with respiration. So if the patient there is no spontaneous breathing, the triage officer will open up the airway. So if after position the airway, there is still no respiration or still no spontaneous breathing, the patient will be triaged as black, deceased, means died. If the patient, after opening the airway, there is spontaneous breathing, those patients will be triaged red. If the patient has spontaneous breathing, next they will check the respiration. Uh, if the respiration is more than 30 in 1 minute, the patient will be triaged red. If the respiration is normal or less than 30, the triage officer will check the patient's perfusion. So checking the perfusion, the triage officer can either check the radial pulse or check the patient's capillary refill time. So at any point, if the triage officer unable to feel the radial pulse or the capillary refilling time is more than 2 seconds, the triage officer should control the patient's bleeding and triage the patient as red. If the capillary refilling time is less than 2 seconds or the radial pulse is present, the triage officer proceed to check the patient's mental status. He should ask the patients to do a simple command. Example, can you please raise your right arm? If the patient able to follow his command, he will be triaged yellow. If the patient unable to follow his command, he will be triaged red. Okay, now I'm repeating the start triage steps again. First step, can the patient walk? If yes, the patient is triage green. If the patient cannot walk, the triage officer will proceed to step 2, which is to evaluate his respiration. 2. The triage officer shall assess the respiration or whether there is spontaneous breathing. If there is no spontaneous breathing, the triage officer shall open the airway of the victim. If after opening the airway, there is presence of respiration, the patient is triaged red. If after opening the airway, there is still no respiration, the patient will be triaged black or white, which is deceased. So if the respiration is present, the triage officer have to count the respiration rate of the patient. If more than 30, the patient is immediately triage rate. If less than 30, the triage officer can proceed to step 3, which is to evaluate the perfusion or circulation of the patient. Next, in assessing the circulation or perfusion, the triage officer got 2 ways in assessing it. Either he can feel for radial pulse or check for capillary refilling time. So at any moment, if the triage officer cannot feel the radial pulse or the capillary refilling time is more than 2 seconds, he should immediately control the hemorrhage if present and immediately triage the patient as red. If he can feel for the radial pulse, then he should proceed to next step, which is to evaluate the mental status or the conscious level of the patient. So finally, the last step. Last step is to assess the conscious level or the mental status of the patient. So the triage officer has to ask the victim to perform a simple command. For example, can you raise your right arm? If the victim unable to follow the command, he is triage red. If the victim can follow the command, he is triage yellow. Okay, finally, we do another revision on start triage. So as triage officer, firstly, you instruct those victims, those who can walk, to walk to walk to a side. Those victims that can walk are automatically triage green. Next, you go to the nearby victim and start to assess their RPM, R respiration. So you assess the respiration. If there is no spontaneous breathing, you want to open up the airway. If there is, after positioning the airway, there is spontaneous respiration, you triage the patient as red. If there is still no respiration after positioning the airway, the patient is triage black. Next, if the respiration is present or there is present or spontaneous breathing, you count the respiratory rate. If more than 30 is triage rate. If less than 30, you assess the patient perfusion. In assessing the perfusion, there are two ways. Number one, assessing the radial pulse. Number two, assessing the capillary refilling time. Either one is good enough. If at any moment the triage officer couldn't feel the victim's radial pulse or the CRT is more than 2 seconds, the patient is immediately triage red zone, and the triage officer have to control the bleeding if present. If the perfusion is normal, the triage officer will move on to mental status. He shall instruct the victim to perform a simple command. Example, can you please raise your right arm? If the victim unable to follow his command, he is triage red. If the victim can follow his command, he is triage yellow. Next is the jump start that used for pediatrics. In pediatric age group, we don't use start, but we use jump start. Jump start is a slight modification for pediatric age group, which I shall tell you the reasons why we do jump start in pediatrics. Okay, so in case one might wonder, how do we determine the age of the patient? You say that adult we use start triage, pediatrics or children we use jump start. But sometimes it's difficult to assess the age of the patient. We cannot ask them to show their IC, right? So how do we know which triage system to use? Actually, it is simple. So if the patient appears to be a child, then you use jumpstart. So if the victims appears to be a young adult, then you use start. As simple as that. So what are the rationale that we use jumpstart in pediatrics age group? Number one, apnea is common in neonates or young child and is usually reversible with good ventilation. Thus, it is inappropriate to take black to a child after opening airway and breathing is absent. Number two, pediatrics has different physiology. They have higher baseline of respiratory rate. Number three, pediatric has difficulty in obeying command, especially after suffering for trauma. Thus, it always presents a challenge to assess their mental status. Okay, next I'm showing you is a diagram of jumpstart that used in pediatric age group, right? So in using the jumpstart, it is start off is the same as the start triage. You instruct the victims that those able to walk or ambulate to move to one side of the medical camp. So those patients that can move or ambulate are immediately triaged as green. Next, you check the respiration or breathing. If there is no breathing present, so one should immediately position the airway of the victim. So after positioning the airway by doing jaw thrust, so if the breathing is present, the victim is triaged as red. If the patient is still apneic, you need to check the victim pulse. If there is no palpable pulse, the victim is triaged as black, which is death. So if there is palpable pulse, you need to give 5 rescue breaths via your BVM. You need to bag the patient 5 times. So after bagging the patient, you assess the breathing again. So if the breathing is present, then the victim is triaged as red. If the breathing is still absent, then the victim shall be triaged as black. If the breathing is present, then you move on to assess the rate of breathing. So in pediatric age group, we use 15 and 45. So if the breathing rate is less than 15 or more than 45, you immediately triage rate. If the breathing is between 10 to 45, then you proceed to assess the perfusion. In perfusion, you can either assess the radial pulse or check the capillary differing time. If you cannot feel the radial pulse, the victim is immediately triage red. If the perfusion is normal, then you assess the mental status. In pediatric age group, we assess the mental status by using AVPU. A stands for alert, V stands for verbal, meaning the patient responds through call. P stands for pain, meaning that the patient responds to pain stimulus. U stands for unresponsive. So if the patient showing abnormal posture on pain stimulus, abnormal posture meaning the patient giving a decorticate or decelebrate position, or unresponsive, this group of patient is triaged as red. So if A, V, P appropriate response, you triage as yellow. I move on to SAFE. SAFE, also known as Secondary Assessment of Victim Endpoint. SAFE is typically used when you have a large number of victims in your medical camp and you have limited resources. And you anticipate that these victims going to stay for some time in your medical camp. With limited resources, you need to re-triage this group of patients so that you will direct your limited medical resources and limited personnel to focus on those group of patients in your medical camp who are salvageable. SAFE, also known as Secondary Assessment of Victim Endpoint. We typically do SAFE after we do start triaging. We do SAFE in our medical camp when we have large amount of victim and a limited number of resources. So those victims that have at least 50% chance of survival, we will focus our personnel, our resources to them. In SAFE triage, we say the value of a victim is equals to a formula, which is benefit over resources required times the probability of survival. So those patients that has higher value, we will focus our resources in treating them. So basically, we see whether the patient's likelier to survive in his injuries or not, right? So those patients who has too severe injuries, we have no choice but to uh, treat them later on, right? In safe triaging, it have comes up with a table showing the treatment priorities, right? So in cases like temporary airway management, meaning that those patient needs airway management to stabilize, their treatment priorities is 100%. And those patients who need pressure bandage to control their bleeding is given 100% of priority. While those patients simple pneumothorax or those patients in shock after compressing bandage, that those patients who need fluids to stabilize is 80% of treatment priorities. Whereas those patients that have needed advanced airway management, meaning that those patients needing intubation, priority is 80%. And those group of patients who need limb manipulation, meaning maybe fractures or dislocation, which need reduction and treatment for vascular supply, meaning that those patients that have need limb management to ensure that good vascular supply is given 80% of treatment priority. Okay, let's say the patient having a moderate amount of burn, 25% part of the body is burned. So this type of group of patient is giving 60% of treatment priority. Those chest trauma patient also 60%. Those spinal injury, again 60% of treatment priority. Those patient with suspected what they call it, compartment syndrome, which require fasciotomy, also given 60% of treatment priorities. Those patients with open wound, also 60% of priority. Those patients with traumatic brain injury with a GCS of more than 8 and above is also given 60% of treatment injury. Whereas those abdominal trauma, urology injuries included is given 50% of treatment priorities. Those TBI patient with a GCS of 6 to 7 is again 50% of treatment priorities. Those burn patient more than 50%, more than 75%, or GCS less than 3, this group of patient is only given 30% of treatment priorities. So this table basically it says that those patients with high treatment priorities, you should focus your resources and personnel in treating them. Okay, those group of patients with low treatment priorities, you should treat them at a later, after you have settled or after you have stabilized those patients that has higher treatment priorities. Okay, get it? All right. So in safe triage, we assess the area of assessment is we assess the patient organ by organ, system by system. Okay, we assess the patient according to their vital signs. Then we proceed to assess their airway, chest, abdomen, pelvis, spine, extremities, skin, neurological status, or mental status. In safe triage categories, we categorize them into 4 groups. Red means those patients require immediate intervention. Yellow means those patients requires intervention but can tolerate a brief delay. Green meaning those patients that do not require intervention to prevent loss of life or limb. Black means those patient is basically dead or unsalvageable or expectant. Expectant means is those patient expected to die. So in safe triage, we assess the patient from time to time. So those patients, after every assessment, they can be moved from one area of triaging to another area of triaging. Okay, let's say you have a patient with crush injury to the lower extremities. So what you can use is the MAS score. MAS score meaning Bankert Extremity Severity Score. So you use MAS score to assess the severity of his injuries. Let's say the score of 7 and more, those patients need amputation. So this patient can be it has to be triaged into um, expectant. All right, not expectant, but to you manage them later on. But those patients we have a MAS score of less than 7, those patients you want to salvage the limb first. Okay, so you give your attention, you give your resources in treating those patients we have a MAS score of less than 7 in salvaging their limb first, right? So for head injury patients, we use the GCS score. So score of 8 and above, these patients have more than 50% chance of normal or good neurological recovery. So this group of patients, you want to focus your resources and personnel in treating them. Whereas those GCS score of 7 and below, probably you can only provide comfort care to this patient. For burn injury patient, probably want to burn injury patient, you want to count the total body surface area that involved in burn, right? So if those patient that has less than 50% chance of survival is more than 70% of total body surface area burn, or those old patient or elderly patient who is 60 years old or more with inhalational injury, or those very young patient, 2 years old or less with 50% of total body surface area burn, or those elderly patient more than 60 years old with 35% of total body surface area burn. Okay, this group of patient, they have high chance of mortality. So we only provide comfort care to them. How about abdominal injury? So for abdominal injury wise, currently there is no data to guide a fair evaluation. So one there is one paper suggests that we give this group of patient we suspect intra-abdominal injury. We give this group of patient 4 mils per kg of hypertonic saline. Hypertonic saline meaning 3% of normal saline, 3% or more sodium chloride. We give them twice, right? If after giving hypertonic saline, the BP still doesn't respond, this group of patient we group as expectant. Probably we will provide this group of patient with only comfort care. So in order to appropriately, more accurately diagnose abdominal injury, so if we have a handheld ultrasound, it would have come in handy. Okay, next I'm going to talk about SWOT triage. SWOT triage also, the whole acronym for SWOT stands for SWOT, Assess, Life-Saving Intervention, Treatment and Transfer. Of SWOT is actually a CDC or Central of Disease Control project. It started in the United States. So they start to develop a national standard for the mass casualty triage, and now basically in the United States, SWOT has been replacing the START triage. So in the SWOT triage, basically there are 4 steps. Okay, step 1 sorting, step 2 is assessing, step 3 is life-saving intervention, step 4 is treatment and transport. The SWOT triage is designed in a way which based on the best evidence available. So you can, as shown in the slide, is the SWOT mass casualty triage algorithm. So I will go to this algorithm step by step and hopefully you guys can follow, right? Okay, step number one. Step number one, also known as global sorting. In step number one, the triage officer basically categorize the victims into three categories. Category one, those victims that are able to walk. So they are assessed lastly, right? And those patients that are unable to walk, they are asked to wave their arm, okay? Those patients that are able to do that, they are assessed second. And for those patients who are unable to walk, unable to wave their arm, they just lie still, they are assessed the first. So in action number one, the triage officer should use a loudspeaker or hailer and giving simple instruction. Example, everyone who can hear me, please move to the designated area and we will help you. So by doing that, he is able to group those ambulatory patients. Those who can follow his command will have the last priority for individual assessment. Next, for those non-ambulatory patients, he will give simple instructions like, if you need help, wave your arm or move your leg. We will be there to help you in a few minutes. So those patients that are able to wave his arm or move his leg will be given second priority for individual assessment. So as you can see, by doing global sorting, you are now categorize those casualties into three priorities. Priority 1, those patients who lie still. Those patients are most likely in obvious life threat. Priority 2 is those patients that are able to wave or do purposeful movements. Priority 3 is those patients that are able to walk or ambulate. So after doing step 1, we move to step 2. Okay, step 2 is the individual assessment. In individual assessment, one should assess A, B, C, and D. A stands for airway, B stands for breathing, C stands for circulation, D is neurological deficit. So beside assessing the patient, you should able to perform life-saving intervention if their ABC is compromised. For example, while you're assessing the airway, if at any time you feel that the airway is not patent, is in immediate threat, or there's no spontaneous breathing, you should open up his airway. In children, one should consider to give 2 rescue breaths if there's no spontaneous breathing. So next, you proceed to assess the breathing, right? So if the patient is tachypneic, you should able to identify whether there's presence of pneumothorax. If there's presence of pneumothorax, one should be able to do chest decompression or needle thoracocentesis. Next, C is circulation. One should able to examine or assess the circulation. If you feel that the circulation is immediate threat, evidenced by poor pulse volume, and there is evidence of major hemorrhage, one should able to control the major hemorrhage by doing compression bandage. Next, if in any case that the victim is a case of cholinergic poisoning, like example is sarin or NX, the assessing officer should able to give auto-injectors antibodies. So you assess the breathing. So after your intervention, you assess the breathing. If the patient is breathing, then you move on to assess back again to see after your intervention whether the patient has stabilized. If the patient has, after your life-saving intervention, the patient is not breathing, then you categorize them as deaf. Okay? So you provide life-saving interventions by control the major hemorrhage, open the airway if no breathing, if child consider giving 2 rescue breath, Do chest needle decompression for case of pneumothorax. Give auto-injectors antidotes we use in nerve gas intoxication or patient with cholinergic symptom. So the auto-injectors antidotes, it contains atropine and pralidoxime, which is the antidote. Okay, next, after you have done your life-saving intervention, if the patient is no breathing, you categorize them as dead. If the patient is breathing, you want to assess the A, B, C, and D again. A, you assess whether the patient is breathing. If he is breathing, is he in respiratory distress? C, you assess the peripheral pulse. Is the pulse volume good? Then you see if the major hemorrhage is already controlled. Then you assess whether the patient is able to obey a simple command. If the patient is stable, then you assess whether the patient is sustaining minor injuries, right? So minor injuries meaning abrasion wound, not significant laceration wounds, a small injury, STI, soft tissue injury, then you give minimal or green zone. Okay, so if those patients that you suspecting not minor injury, for example, intra-abdominal injury, right? The pain, patient got tender over the abdomen and got bruises on it, which you cannot rule out intra-abdominal injury, but currently the patient is still stable. So you classify the patient as delay or yellow. So after, if you assess the ABCD, at any time you feel that the patient airway, breathing, circulation, or neurology is not stable, then you have to think of whether the patient is likely to survive in the current resources. If yes, then you triage the patient as red or immediate. If no, you triage the patient as gray, which is expectant. So the triage category, so the triage categories got red, immediate, delayed, yellow, green, minimal, expectant, gray, and deaf, which is black. In deaf is patient is not okay. Definition of that is those patient that is not breathing after opening of airway, or in children that who is not breathing after you have gave 2 rescue breath. If those patients that is not breathing, you must tag them as deaf or black tag. Okay, we need to tag those patients to prevent re-triage. Okay, do not move those dead patient, right? So we wait for the, because those we wait for the forensic team to move the patients, right? So if the patient is breathing after you open up the airway, the patient is breathing, then you need to conduct the next assessment. Next, immediate group or red zone of patient. Those immediate group or red zone patient, meaning they have peripheral pulse, they have a weak pulse volume, or they are in respiratory distress, or they have a major hemorrhage which is not controlled. Example, they have an exsanguinating wound that keep on pouring up blood, right? Or they are unable to follow simple command. Next, they are likely to survive given available resources. So those expectant or gray tag, those patient is which unstable, right? They have a weak pulse volume, they are in respiratory distress, their hemorrhage is not controlled, and they are unable to follow simple commands, and they are unlikely to survive given available resources. Those patients we tag gray or expectant. Okay, expectant does not mean death, right? It's just we tag them because it's important for us to preserve our precious resources. This group of patients receive comfort care or resuscitation later on when resources are available. So this group of patients are likely suffer from serious injuries. They usually have a very poor survivability, even with maximal care in a hospital or pre-hospital setting. Example of this group of patients are those who have 90% of total body surface area burned, right? Or those patients with severe traumatic brain injury with their brain matter exposed. Okay, delay. Delay is a yellow zone patient, right? So this group of patients usually are those patients that suffer serious injuries, but their vitals are temporarily stable, right? So this group of patients requires care, but management can be delayed without increasing morbidity or mortality. Example, long bone fracture, as seen in the photograph, okay, patient having an ankle fracture with dislocation, right? So this group of patients they are likely to survive, right? But they need immediate care. Example, this group of patients, they need immediate reduction, right? Immediate reduction and proper splinting to salvage the limb, right? So in yellow zone or sorry, in those yellow zone categorized or delay group of patients, those patients have stable vital sign, right? So they have a good peripheral pulses. They are not in respiratory distress. Their hemorrhage is controlled, and they are able to follow commands, right? And their injuries are not a minor one and requires care. Next, we move to minimal. Minimal is essentially a green zone patient, right? So again, this patient is having stable vital signs, right? Their conditions are stable. They has a good peripheral pulse. They are not in respiratory distress. Their hemorrhage is well controlled, and they're able to follow simple commands, right? And their injuries are minor. Example, abrasion wound, bruises, soft tissue injury, right? So this group of patients only requires minor care or sometimes no care at all. Okay, like examples like I mentioned earlier, they have abrasions, minor laceration, nerve agent exposure with minimal symptom. Okay, after patients are categorized, we would like to prioritize the transportation of the patient, right? So again, the process of triaging is dynamic. Dynamic meaning we have to re-triage patient if patient condition changes. The reason is we want to correctly triage those patients so we can correctly direct our resources to them. Okay, next we thought why SOT is slowly replacing START, right? So we look at the benefit of START first, right? So what is the benefit, the good things about START, all right? START number one is easy to apply, okay? It's not complicated. And it can use by non-medical personnel, for example, our bomba, our JPAM. Okay. Then number two, it is universally used in Malaysia. All right. There is no barrier in communication. So if you apply START, there's no problem. You can communicate easily with the bomba, with the JPAM, with the what do you call that? With the police, right? So what are the disadvantages of START? Okay. Because you look at the START, right? It applies to the next available casualty. Okay, start it assess the casualty most nearest to the medical personnel. So it might causes delay in assessing and treating more critically ill casualty who lies further from the triage officer. And number two, start triage, it doesn't advocate neither decompression. Thus, in any case of tension pneumothorax, the casualty might die if there is delay from extrications to the medical camp. Number three, start triage doesn't advocate auto-injector antibodies, which can be life-saving in cases of nerve gas intoxication. Lastly, Start triage doesn't consider group of casualties with serious injuries, which is the expectant. So, example, if you have a severe head injury with brain matter exposed or severe uncontrolled bleeding in those trauma patients, whom their survival is unlikely given the limited resources available on the field and the severity of the injuries. Triage again, right? Okay, so in the medical camp, it's important for us to organize the patients in the medical camp. Okay, from here you can see the medical camp. There's only one way in, one way out, right? One way in is when the triage officer will bring in those patients and from outside the camp inside, and in the middle of the camp they will put them either on in the immediate care zone, the left side, or the delayed care zone, which is the yellow zone on the right side. Okay, then after that, um, when the ambulance is available, those patients will move outside of the camp, through the back of the camp, and to the hospital, right? So those patients who are died will put beside the medical camp, which is handled by the police and the forensic team, and those able to walk will be treated separate from the medical camp. Okay, those green zone patients will be registered first, will be documented, registered. After then, they can either be discharged to the local clinic, or they can they can take a transport to the nearby clinic by themselves, right?